Thank you for joining us for our first Department of Medicine Grand Rounds. My name is Apurva. I'm currently the Internal Medicine Chief Resident, and I am pleased to announce that we have two fantastic speakers here today, both of which I will introduce next. Just a few quick reminders. Today's CME code is 43430. We ask that you hold your questions. We hold your questions until the end of the presentation. And feel free to enter any questions throughout the presentation into the chat, and we'll get to them at the end. First, I would like to introduce Dr. Jessica Goldstein. After finishing her medical education at Weill Cornell Medical College, Dr. Goldstein completed her emergency medicine residency training at the University of Illinois at Chicago Medical Center and went on to complete her fellowship in ultrasonography at Metro Health. Currently, she is the Medical Director of Emergency Medicine Quality Network, an attending ED physician at Ahuja Medical Center, and the chair of the System Sepsis Committee and an assistant professor of emergency medicine at Case Western Reserve University. Next, I would like to introduce Dr. Rana Hejal. Dr. Hajjal originally hails from the American University of Beirut in Lebanon. She completed her internal medicine residency and pulmonary critical care training here at Cleveland. And she's been in Northeast Ohio since then. She's a clinical associate professor of medicine at Case Western Reserve University and is currently the medical director of Main Campus MICU. For the House staff, Dr. Hajjal represents the essence of critical care medicine and is a true teaching attending in every sense of the word. Please join me in welcoming Dr. Goldstein and Dr. Hajjal to today's Grand Round series. Thank you.
Thanks, everybody, for the warm welcome. So I'm going to be presenting on sepsis and how to save lives from sepsis. And I just wanted to start the talk by greeting all of you, especially the interns for medicine. This is really an unusual time to be practicing in medicine. We had a meeting today with some of my emergency medicine colleagues, and this is a really challenging time in the EDs, and I'm sure on the floors as well, with all the capacity constraints. So I just wanted to thank you guys for coming into medicine and being part of the team and really helping to be part of this solution with saving lives with sepsis. So first, we're going to just go through the outline of the talk this afternoon. We're going to start with why is learning about sepsis important. I'm going to review sepsis bundles and how they impact mortality with a focus on the initial sepsis management. And then we're going to talk about how you, in particular, can save lives from sepsis. So just going through some statistics. 1.7 million cases of sepsis in the U.S. annually, with 850,000 ED visits annually. More than 250,000 lives are lost in the U.S. annually due to sepsis. And the cost for these, for the care of these patients is really escalating. From 2012 to 2018, the cost to care for patients that were in the hospital and subsequently discharged to nursing homes has risen from $27 billion to $41 billion. When you look at sepsis in the hospital, about 6% of all hospitalized patients have sepsis. So you guys are going to be caring for a lot of these patients in your careers. 22% mortality rate overall across the U.S., so that includes septic patients as well as septic shock. And this is a really sobering statistic. 1 in 3 patients who dies in the hospital has sepsis, and that may even be an underestimate. It may be up to 1 to 2. Here at UH, looking at our numbers, patients that have a diagnosis code of sepsis, about 3,000 across the system. So those are patients that get admitted through the emergency department and their primary diagnosis is sepsis. If you look at the overall diagnosis of sepsis, so maybe they get admitted for another reason and sepsis is a secondary diagnosis, that number goes up to about 5,000. So you guys are going to be taking care of both ED patients as well as septic patients that develop sepsis on the floors. And our current mortality rates unadjusted in the community hospitals, it's about 11%, and at CMC it's about 20%, and that's knowing that you guys have a higher acuity patient population here with a lot of comorbidities. This is a very new chart, and I'm sorry that it's a little bit dull, but this is looking at at year-to-date numbers for diseases in the hospital. And if you exclude number 1 for liveborns, which is an exciting, pleasant number to look at, the number 2 and number 3 diagnoses, looking at adjusting by race. So number 3 in the black population is COVID, number 4 is sepsis, and in the white population, number 3 is sepsis, number 4 is COVID. So very high incidence of this, and also, showing how this is relevant, how this is compared to our COVID numbers. So what is sepsis? And this definition has really varied over the past decade or so. Current definition that we are accepting is a life-threatening, dysregulated response to infection, evidenced by end organ dysfunction. And at the extreme level, with shock, you have circulatory collapse, okay? So looking at what this looks like on a physiologic level, using a bacterial sepsis as an example, you have your bacterial endotoxin, and then you have your cytokine storm, which has been, in the media a lot. So what exactly is this cytokine storm? It has a different effect on your different organ systems. And there's a continuum of, regulated normal response to your cytokines, and then there's a dysregulated response to your cytokines. And this is the area of the sepsis continuum, where we're going from having a normal response to a dysregulated response, and then ultimately hemodynamic collapse with septic shock, and if you can't recover from that, then death. So over time, we have modified our definition of what sepsis is, and this winds up having an effect on our coding, as well as on some of the governmental agencies like CMS that is holding us to these accepted definitions of sepsis and who they're abstracting for our core measures. So these definitions have evolved over time, and these are coming from the Surviving Sepsis campaign. So we are on Sepsis 3, the most recent definition of that was from 2016, and that is similar to the definition that I gave a couple slides ago, looking at sepsis as a life-threatening infection with organ dysfunction, and they suggest using the SOFA score, which we'll get into a little bit more detail for how to document your organ dysfunction. Severe sepsis is a coding terminology. You don't necessarily have to use that, but coders may be asking you whether your patient has severe sepsis. They're basically asking you, does this patient have organ dysfunction? And then when you get to septic shock, this is when you're starting to use pressors with pressors required to maintain a MAP of greater than 65. And the Surviving Sepsis campaign suggests looking at your lactate after you have started your pressors and resuscitated your patient to see whether they have responded or not. So a lactate of greater than 2. So when we're talking sepsis, there are a lot of these acronyms, SIRS, SOFA, QSOFA. So I'm just going to go through them so you're familiar with them. So SIRS, when you're looking at your SIRS criteria, we're looking at mostly vital signs, but also a white blood cell count. So your SIRS, you have a temperature elevation or a decrease less than 36, heart rate greater than 90, respiratory rate greater than 20, and then your white cell count greater than 12 or less than 4 with greater than 10% bands. These are calculated on our EMR. You get a sepsis alert. It's based on these SIRS criteria. Now, the critique of the SIRS is that it's very nonspecific. You can be on an exercise treadmill and have positive SIRS. And there's a great overlap with other disease processes that are important to rule out and to be considering on your positive SIRS patients, such as trauma patients, pancreatitis, et cetera. So SIRS we're using for surveillance, but it's really nonspecific. SOFA is your sequential organ failure assessment score, and this is using a combination of your oxygenation level with some lab values, so coagulation, liver enzymes, what your MAP is, and then any level of encephalopathy, as well as your renal function. And this has been a validated tool to identify organ dysfunction, as well as a predictive tool, because if your score is greater than 11, you have a 90% predicted mortality, okay? So you can, when you're in the ICU and working with Dr. Hajjal, you can get used to calculating your SOFA scores and your changes in delta scores. The Q-SOFA was suggested as possibly a replacement for SIRS, but that has really not panned out because it is not sensitive enough to be detecting patients who are septic. But what it can be used for is to predict mortality again. So if you have somebody who you're getting a report on from the emergency department and you're trying to tell whether that patient is appropriate for the floor or perhaps needs to go into ICU, you can look at what their Q-SOFA score is. So it's a very simple score looking at any level of encephalopathy, respiratory rate greater than or equal to 22, and a systolic blood pressure less than 100. If their score is 2 or greater, it has up to 3 to 14 times the mortality risk. So these are patients that you should consider ICU care for, consider if you guys have step-down services available, but these patients need a real close eye. So what's going on? Are we getting more septic patients, or are we just coding more for sepsis? So if you look at some numbers, this gray line above here is showing the incidence of coding for sepsis. And over time from 2009 to 2014, that number has really gone up. But if you use just clinical criteria with somebody who's being treated with antibiotics, who has evidence of end organ dysfunction, the line is not quite as steep. So there certainly is some variability in coding, and insurance companies have noticed this, and they don't want to be paying for patients that don't have clear organ dysfunction. So when you are documenting your charts on somebody who you're documenting has sepsis, make sure that your documentation fits what your diagnosis is. Make sure that you're documenting that this patient is ill, they have a life-threatening infection, and this is what we're doing, X, Y, and Z. And you should be rewarded for a great resuscitation and taking good care of that patient, because maybe they were septic for the first 24 hours, and then, they're lactate cleared, they're having good urine output, and you're able to get them home. But you still treated a septic patient. So just make sure that your documentation fits what you're coding for. So why should this matter to you? So if you look at the mortality of some of our time-sensitive conditions that we as a hospital prioritize with these team approaches, you can see our team approach for ischemic stroke, there's a 30-day mortality of about 15%. Trauma teams, all in, have a predicted mortality of about 4%, and then STEMIs, depending on whether they had a cardiac arrest prior to arrival or not, can have anywhere from a 4 to 37% predicted mortality. Sepsis is right up there. It's 22%, okay? So this definitely fits in with having a system response with a team approach for a time-sensitive condition. Of the patients that we see who are septic, what percentage of them is it preventable? Because sepsis doesn't usually just happen in a bubble. Sepsis usually happens to patients with comorbidities. So this was a study looking at how many of these cases are actually preventable, and it's probably around 11 or 12%. So that's the patient population that we're really trying to make an impact on, preventing somebody who should not have died. If you have an older patient in your family, or you're taking care of an older patient, I think that this is also just a helpful diagram to look at a new model for care and how to incorporate palliative care. So the old way of looking at the dying process was aggressive care, and then when there really is no point of return, you make your palliative care consult. But really, we're trying to understand, that there are more opportunities to intervene, particularly in somebody that's having recurrent admissions for sepsis. And we should be considering a palliative care approach earlier on so that people can understand and have a share in the decision-making of how they want to spend some of their last days on Earth. Because sepsis follows people. Mortality follows people after they leave the hospital with sepsis. This is looking at mortality within 1 week of sepsis from their hospital discharge, within 6 months, 1 year, and 3 years. This top line is patients that have septic shock. So 40% mortality with septic shock 1 week out, up to 60% within 6 months, and up to within 1 year, about 70%. So these are pretty sobering numbers, and we need to, approach these patients with care and understand how they want to spend their lives. This is another diagram just showing you the impact that sepsis has on people's quality of life as well as their longevity. So looking at your health on the y-axis and time, in a normal trajectory of a healthy person, and this is sort of the chunk that sepsis takes out of that person's life. And some people have a rapid decline. These are the patients more with septic shock, and then here's a more of an undulating trajectory with patients that are getting readmitted and going into skilled nursing facilities. But no matter what, sepsis is having an impact on people's quality of life and their longevity. So what can we do? How can we save lives from sepsis? There are a lot of key guidelines and reissuance of guidelines, and for some of the people that are in the audience here, you can date where you trained based on this timeline and which guidelines you were following. I was in the Manny Rivers, early goal-directed time frame here, and you can remember how we were resuscitating patients and putting in central lines and measuring central venous oxygenations. So I wanted to familiarize you guys with what our current sepsis clinical practice guideline is. This is available on the UH Provider app, and this is showing just a breakdown. We start with identifying an infection with sepsis, and we have our SIRS surveillance. And then this is our time zero. So this is when we want you guys to huddle and think about sepsis and what do we need to do to initiate care to these patients. If you suspect sepsis, go ahead and call a sepsis alert. And Dr. Hajjal is going to speak to this, how you call a sepsis alert on the floors. We want you to use the Sepsis Order Set. It's built in with broad-spectrum antibiotics, your fluids, your lactate. Reevaluate the patient once you start getting labs back. Do they have any organ dysfunction? These are some things to look for organ dysfunction. If the patient's in shock with a lactate greater than 4 or systolic blood pressure less than 90, MAF less than 65, go ahead and administer fluids. The order set is built in to do an ideal body weight fluid goal. And then reassess the patient. See if this patient would benefit from a palliative care consult. If your hypotension is persisting, go ahead and start pressors and repeat your lactate and get the patient admitted where they need to go. If you work in the ICU, then you have this ICU tri-leaflet, which goes into a lot more details on your care of your patients with septic shock and fluid management. And if you work in the ED or if you're accepting a patient from the ED, you may see this sepsis checklist that we've been using to make sure that we're checking all of our boxes for reperfusion exams, some of the SEP 1 criteria that CMS requires in order to receive credit for the good work that we are all doing, understanding that there are a lot of check boxes to meet SEP 1, and so we want to remind ourselves to just get credit. So we're going to go through some of the key components of a sepsis bundle and show what the evidence is for performing these tasks. So again, I was in the Manny Rivers era. Dr. Mitch Levy has done a fantastic job of leading the Surviving Sepsis campaign over the years. And this is what we were looking at in 2001. So this is the first bundled care that was accepted was early goal-directed therapy. And we did a lot of things with central lines and giving blood products. And what it showed was that early goal-directed therapy had a mortality rate of 30% for septic shock, and standard therapy was 46%. So this was really promising. The Surviving Sepsis campaign pulled together and worked with the Institute for Healthcare Initiatives, and they put together a multi-hospital bundle that was looking to follow the early goal-directed therapies and establish this as a new standard. And what they showed was that over time, their bundle compliance definitely went up. When you're paying attention to something, your compliance with whatever that checklist says is going to go up. And the mortality also went down. So this was very encouraging. But when these bundles were attempted to be reproduced in larger studies in the U.S. and in Australia and in the U.K., we really found that there was no difference in 60-day mortalities looking at early goal-directed therapy versus a protocol-based approach without central lines versus standard care. And similarly, early goal-directed therapy versus standard care, there was no difference. So what are we to conclude? I mean, we learned what standard therapy is. It's not that early goal-directed therapy doesn't work. It's that our standard was really improved. We learned that early resuscitation with fluids and antibiotics is very important. And transitioning to pressors when patients are not responding to fluids is also very important. And that you don't necessarily need a central line for all these patients or arterial monitoring. So the Surviving Sepsis campaign speaks. In 2015, they said, okay, well, we're going to be changing what we consider as part of our bundle. And they went to a 3-hour and a 6-hour bundle that did not necessarily require a central line. So now we're measuring lactate, we're administering broad-spectrum antibiotics with blood cultures before, and then there's still this fluids expectation for patients who have shock. So, and CMS listened in 2015 as well. That's when they started Step 1, saying that every hospital has to have a 3-hour and a 6-hour bundle. New York started these bundles even before CMS required it in 2013. And the bundles are very similar to Step 1. So blood cultures, lactate, and broad-spectrum antibiotics, and then a 6-hour bundle with fluids for lactate greater than 4. They also started a pediatric bundle, which was really ahead of their time with a 1-hour bundle. And what the New York studies show is that they had very high compliance. If you require something through the state, you're gonna have pretty good compliance. So their 3-hour bundle had up to 82% compliance. Their overall mortality was 22%. And then just to show you how hard some of this is to achieve at a teaching hospital, if it makes you feel any better, their 3-hour bundle at the teaching hospital is 19%. So you can take that in mind when you're looking at your compliance, which is better than that. So your New York mandatory sepsis bundles show that here's your hospital mortality on the y-axis, and they looked at whether time to completion of a 3-hour bundle impacted the mortality. And what they showed was that beyond 3 hours, the mortality actually went up. And the same can be said for administration of antibiotics. Beyond 3 hours, your time really went up. On the contrary, they did not see any association between timing of fluid completion and mortality benefits. So that's the area that has really continued to be challenged by the sepsis community. So does bundle care work? Oh, yes, it does, and we just need to distill the components out that make an impact on saving lives. And really being part of a major PI project also helps as well. So having a sepsis coordinator that's giving you timely feedback, which CMC just got a sepsis coordinator this past month. All right, so we're going to talk about antibiotics. So Banks Osin for everybody, is that the answer? For those of you who were around for when we tried this with a pneumonia requirement, it did not work. Everybody just got a Z-Pack at the door, 500 of Zosyn, of Zithromax, upon triage. And so it didn't allow for us to be really targeting the appropriate antibiotic, because it's not just giving an antibiotic, it's giving the appropriate antibiotic. But in a very early study in 2006 looked at delays in antibiotic timing, particularly in patients with septic shock, does have an impact on mortality. So just looking at the mortality back then, 56%. So that's a very high mortality. These are very sick patients. But each hour that antibiotics were delayed was associated with a 7% decrease in survival. And that is impressive. And that's where this, September Sepsis Awareness Month, if you've seen this flyer, that's where this comes from. So for every hour treatment is delayed, the risk of death increases by as much as 8%. All right? So we took a look at, in the Surviving Sepsis campaign, they took a look at their data, which includes not just septic shock, but also sepsis, and looked to see what the hospital mortality rates were for every hour that antibiotics were delayed. So, in your first hour, you're obviously seeing some very sick patients that don't have chances of survival. So, high mortality at 32% in that first hour, and then it goes down to 28%, staying steady, and then right around 3 hours, it starts to pick up again. So, this gives some rationale for why we have a 3-hour recommendation on the step 1. And as well as this was a slide that Dr. Hejal shared with me, that it's very important to have your appropriate antibiotics, because if you give inappropriate antibiotics, you're right back up there around the 40% mortality mark. So antibiotics, of course, antibiotics work. The best evidence is in patients with shock. If you're not sure of the etiology of their sepsis and the patient's presenting with shock, go ahead and give your broad-spectrum antibiotics. But if not, you've got some time to think about it and consider a more targeted approach. All right, lactate, the dreaded lactate, getting repeat lactates, shortages of gray top tubes across the U.S. Everybody's trying to get compliant with their bundles. And lactate, why is lactate elevated? It's not just sepsis. There's a whole differential for why a lactate can be elevated. But at the end of the day, lactate elevations greater than 4 are bad no matter what the cause is. So this is looking at lactate as a predictor of mortality. And this is a septic patient population, and you can see that the 28-day mortality is in the black bar graph, and death within 3 days is in the gray. So lactates less than 4, about a 5% 28-day mortality. Lactates up to 2.4, about 5% mortality. Lactates up to 4, 9% mortality, and then a lactate greater than 4, up to 28% mortality. So yes, consider what your differential is for the lactate, whether they're on metformin, whether they're a liver patient, but take a lactate greater than 4 very seriously. This is a pre-hospital study, and just thinking, what our connection is with the pre-hospital teams and ambulances bringing patients in, there may be an opportunity for them to be drawing lactates earlier and providing us with that number so that we can further triage, particularly when we're dealing with capacity issues like we are right now. If we can have some clue that we really need to take care and prioritize care of this patient, then that would be helpful in prioritizing our resources. So does measuring lactate in and of itself help to save lives? It's really a proxy measure that you are following a bundle, and it does help to predict mortality so that you can target your efforts. Fluids. So this is the most controversial area. Does fluid compliance matter? So this is looking at one of the New York hospitals that's been doing this for a while and looking at good data. And it shows their levels of compliance depending on where they are working and their non-compliant level. These are their mortalities. So their mortalities with compliance with fluid and their mortalities with non-compliance with fluid, and there really is no difference. So looking at another study, this is the SOAP study, which is hinting that excessive fluids could perhaps be harmful. So these are ICU patients that were admitted with a diagnosis of sepsis, and having a positive fluid balance was actually associated with an increased odds risk of dying. This is a similar study looking at ICU mortality. Overall mortality of these patients was 34%, and this is looking at the positive fluid balance. So the top blue line is non-survivors, and the green line is survivors. So when you look at their fluid balance on day 4, the non-survivors had a much higher positive fluid balance than the survivors. So we are looking to try to thread that needle on giving the right amount of fluids without overloading them in third spacing, so to try and avoid that tissue edema and strike the right balance with fluids and pressors. The SMART article was looking at your choice of fluids and saline versus balanced fluids with lactated ringers or Plasmolite. And this is an interesting study looking at your 30-day mortality. So the balanced fluids had a 26% mortality, and the saline had a 31% mortality. So this is giving some evidence of shifting towards a balanced crystalloid approach. And this is a study that is currently going on. I haven't heard any preliminary data yet, but this is looking at a liberal fluid approach versus early pressors. So the study design is looking to start pressors early or load them with fluids early and start pressors later. And this will be very interesting to follow to see if we're going to change our approach. So mixed evidence with fluids, and we're really shifting towards the crystalloid fluids and really having an individualized approach, understanding that 30 cc's per kg is just not the right idea for every single person. People have comorbidities. We really need to take a targeted and individualized approach in seeing whether somebody is fluid responsive or whether your fluid boluses are harming the patient. And how can we be helped? Are there predictive analytics that can help us to identify our sickest patients without making us all go crazy? Because the alarm fatigue is real. This is actually a national patient safety goal on alarm management, understanding that there are unintended consequences of alarming, because then the more important alarms just get ignored. So how can we target the appropriate alarms? So looking at ED screening tools, this is a comparison of SIRS, QSOFA, and NEWS. And the best performance of these tools was actually looking at NEWS. And the pieces that go into the NEWS is projected on the left. So it's all vital signs. So NEWS outperforms SIRS and QSOFA in both the sensitivity and the specificity. In this University of Chicago ED, if they switched from SIRS to NEWS, they would have had 9 fewer sepsis alerts in the ED per day, which is significant. I mean, that's conserving resources for where you need them to go. So this is something that we're actually looking into at UH. We're looking into a new predictive analytics tool for surveilling for sepsis. So hoping to give some reprieve to those nurses that are getting these sepsis alerts, sometimes every 8 hours. And paging you guys and, causing some consternation. So where are we now? So the Surviving Sepsis campaign issued more recommendations in 2018, trying to advocate for a 1-hour bundle, expecting fluids, lactate, and initiation of pressors all within 1 hour and broad-spectrum antibiotics. And, many people have said, okay, pause, this is just too aggressive. Both FACEP, American College of Emergency Physicians, as well as Society for Critical Care Medicine recommended not implementing this 1-hour bundle because we really wanted to be able to understand what is in the differential for this patient that is presenting with these SIRS vital signs. Perhaps this is sepsis, but perhaps this is a PE. And if I flood this patient with fluids who has a PE, then I could perhaps put them into pulmonary edema and I could worsen the situation. So when it's clear that it's sepsis, yes. When you've identified that the patient is septic, go ahead and get your timely antibiotics. If they're septic, if they have shock, go ahead and initiate your fluids, see whether the patient's fluid responsive or not. But if you are not sure, you can take a little bit of time. It doesn't all need to be completed in 1 hour. These are some quotes that you can read from some thought leaders in sepsis. I'll just read the first one. So our collective uncertainty on how best to identify and treat sepsis renders it an urgent priority for research and also an abysmal target for quality improvement by way of a rigid federal government regulation. So we're really trying to influence National Quality Forum in making some adjustments. There was actually a new amendment to expectations for SEP1 in June, allowing for an exclusion of the fluid bolus for patients that have end-stage CHF or end-stage renal disease. So just make sure that that's part of your documentation of why you did not give fluids. This is a recent paper from emergency medicine on early care of adults with suspected sepsis in the ED and out-of-hospital environment that was signed on by multiple societies, including IDSA, Society for Critical Care Medicine, Society for Hospital Medicine. And I would encourage you all to take a look at this paper. It's got a lot of great current evidence-based recommendations. And, we just need to understand there is this tension currently between Surviving Sepsis campaign, SEP1, ACEP and Society for Critical Care Medicine, as well as our coding and billing people. But at the end of the day, you just need to take care of the patient in front of you, all right? Patients first is always going to be an excellent motto to stand by. You individualize your care for that patient. Once you identify sepsis, get things going quickly. This is the care flow diagram that we came up with a few months ago with Dr. Hejal, myself, Dr. Hughes, and several others on what our UH approach would be for fluids. And we came up with this prior to the SEP1 bundle changing, allowing for exclusions for CHF and end-stage renal disease. But what we recommend is that you use the sepsis order set for your fluids. We have adjusted, we have lactated ringers on that now, and that give a 500 cc fluid bolus for patients that have septic shock or a lactate greater than 4 and see what their response is. If you are very concerned, you can do a straight leg raise and see what their response is, and that can mimic a fluid bolus. And then you look for whether the patient is fluid responsive or whether they're being harmed. So signs of fluid responsiveness are mental status improvement, increased urine output, increased cap refill, and then harm would be, developing pulmonary edema, okay? So if you have a patient who is fluid responsive, continue your fluid boluses. There's no need to wait for the 30 cc per kg fluid bolus to start pressors. You can start pressors early on. And if you have signs of fluid harm, then stop and just go ahead and go on to pressors and just document why the patient didn't receive the fluid bolus. As well, we do have a system policy on pressors that it's okay to start a patient on pressors peripherally for 8 hours, and you can work on getting your line if they continue to need pressors after that period of time. So I just went through and made a table of Surviving Sepsis campaign and their approach to these different areas, as well as what the SEP1 guideline says, what the ACEP task force says, and then what our UH approach is. So our UH approach for bundle care, we're still following the 3 and 6 hour bundles as spelled out in SEP1. With antibiotics, we do want to encourage 1 hour once we have identified that the patient is sepsis and we know what the infectious source is, not from the time of arrival in the emergency department or the time that they show up on your floor. You can be judicious, but if you don't know what your source is and the patient is shocky, go ahead and administer broad spectrum. For lactate, we are sort of beholden to SEP1, but the EMR is arranged such that you automatically trigger a repeat lactate on anybody who has a lactate greater than 2. So it sets you up to allow you to document what the repeat lactate is. In terms of fluids, we have added lactated ringers to our sepsis order set. We encourage an individualized approach for fluid harm versus fluid responsive. And then the screening tools is still a work in progress. As we make our switch over to Epic, they will have some different tools built in. So we are trying to get away from SIRS, understanding that it is nonspecific, and trying to get to something that is sensitive but more specific. So how are we doing here at UH? This is a look at our status data. That's our quality data. This is what we report out at our quality meetings, and some of this data is reported out to CMS. So this is looking at, and we excluded COVID patients from this data just to stick with the standard patient population prior to COVID. So this is looking at all of our inpatient DRGs. You can see where your facility is. If you're here at CMC, if you're zooming in from any of the other facilities, you can see how many patients you have with sepsis over the years. The mortality rates have gone up and down. This is CMC on the left, hovering around 20%. And this is the community hospitals on the right that are hovering around 11%. And this is really a concerning trajectory this is last month's data. This is August. In the community hospitals, our sepsis mortality is spiking. Okay, and that it's not that we don't know how to take care of these patients, it's that we are all under a tremendous amount of stress with capacity issues going on right now, and it is affecting our patients. So we need to help out our nurses any way we can in recognizing that this patient is septic. If you get a doc halo from a nurse asking you to check on a patient, please be responsive. They need our help. Okay, they're really in extended ratios, and we need to do what we can to improve care. This is looking at our risk-adjusted mortality overall. So to my point that we know how to do this, we absolutely know how to do this. Back in May, April, June, we were below our risk-adjusted mortality overall at CMC and in the community hospitals. So when we are under normal situations, we can do this. So that is very encouraging to me. The highest mortalities that we have in the system are patients that are being transferred. And this is a system initiative looking at mortality of patients that are transferred here to CMC. CMC's mortality rates for transferred in for sepsis is 31%. And you guys have the highest number of patients that are transferred in. The next highest number of patients that are transferred in are transfers to Geauga. So, what's going on with these transferred in? It's probably a combination of real higher acuity patients that are wanting to get to a higher level of care, but it also could be that some of these patients are past the point of intervening. So we're starting to look at these patients from the sending facility perspective to look at A, was there an opportunity for palliative care, and B, was there any sort of quality issue that somebody should have been intervened on earlier, okay? Because we've got to get better at this at patient selection for transferring to the quaternary centers. So our sepsis HRM work effort, we are really focusing in the ED right now because about 90% of the patients that come into the hospital with sepsis start their care in the emergency department. We're switching our predictive tool from SIRS to Radar, which is a combination of news as well as other predictive tools. And we're reviewing our highest mortalities in the way that I just mentioned, as well as looking for how to optimize our documentation to make sure that these patients are getting appropriate risk adjustments. Make sure that your patient looks as sick as they actually are. Across the enterprise, we're doing some excellent work. Rainbow Babies and Children just started their sepsis early management program in the ED, and that's being piloted here at Rainbow, and it'll be piloted at St. John as well. Shout out to the OBGYN team. They just initiated their first module on sepsis care and early management. And the Sepsis RS team being led by Dr. Hejal, she's going to speak to that in just a moment. In summary, we need your help. You guys are going to take care of a lot of septic patients on the floors. You may be taking care of patients that develop sepsis. The patients that develop sepsis on the floors have a 20% higher mortality than the patients that start from the emergency department. So your awareness of these patients is really critical. Every 20 seconds, someone's diagnosed with sepsis. At every 2 minutes, sepsis is taking a life. So please, round on your patients, help the nurses out, think about sepsis in your differential once a day for each of your patients, and you can definitely save a life. I'm going to ask Dr. Hajjal to come up and speak about Sepsis RS.
Well, thank you so much, Jessica. This is great. Dr. Goldstein has done me a huge favor by doing this talk. I just can speak on 2 slides that I made. Frank and I were talking about mortality in the community hospital increasing as our mortality decreases from sepsis because they cannot transfer them in. So it's a positive thing. Anyway, so for this, I have to speak through this. I have to. I can't. I have to stand like this and stop moving. Okay. So the sepsis, as you know, it's kind of is dear to anybody who works in any ICU. The medical ICU in particular receives a lot of patients from ED or from the floor because of concerns for sepsis and actual diagnosed sepsis. For a few years now, we've been in HRM as part of observers of all the great work that has been done, but our mortality rates keep on increasing. So just like a couple of months pre-COVID, we decided to create the Sepsis RS, which is we as the ICU will go up and help you guys at the bedside to figure out whether we can impact mortality or not. Unfortunately, with COVID, we had to kind of put a halt on it just because it was impossible to take care of everybody at the same time. And we kept on just simply encouraging using order sets and kind of making diagnosis, documenting, and reviewing or whatever. But we didn't really make a very good impact. Partly it's because residents move, residents change, and it seems we don't really, we have a great impact as we do the talk, and then maintenance of education doesn't get on board. So we have a great effect on the month of the lecture or on the month in the ICU, and then it fades off until the next year when we do it again. So there obviously we had some issues with that. So we came up with this idea of creating a team that will go to help you out, but because of resources, this team has to be kind of managed from within, I would say. So we called ourselves Sepsis RS, similar to what we did when we created Code White, and with the initial goal is to make sure that we are trying to improve outcome across the system in general, but in particular at main campus at the CMC. And the MICU would reach out to patients and play a role in taking care of patients, not taking over unless it's a critical illness that needs to transfer the patient to the ICU. So we got the help from the Code White team, which will be referred to as the Rapid Response team, in addition to a sepsis trigger. As you know, in the EMR, SIRS has been the sepsis trigger for a while, but radar is taking over. You know what the radar is, right? So radar is a scoring system that really has all its components come from news, which is nothing but the National Early Warning Signs that was created in Britain. Which aided a lot in the work of patients who are very ill. In addition to the vital signs, it added two things, understanding that the vital signs include the oxygen saturation. It added two things. It added the mental status to it. And it added whether patients were on oxygen or not on oxygen. And they can come up with a score that goes one way or the other. Through several meetings, actually, we've been able to get IT to help automate this calculation. In addition to some program that came up about that the IT department has bought to predict sepsis mortality. So the combination of these two will come up with a score to radar. And that number, which can go up to 16 if I remember well, it will start to trigger a page to the rapid response nurse at 9. And then we decreased it to 8 so that we capture a little bit more people. So once that happens, that trigger, the nurse knows there's a radar, a bedside evaluation by the rapid response nurse will go on. And during that evaluation, there's a series of questions and responses that they will figure out if sepsis is the cause of this radar alert. If that's the case, a call will go to the MICU, and one of our APPs will go to the bedside with the primary response, with the primary care team. So you have a rapid response nurse who's a critical care nurse. You have an APP from the MICU who are very, very well versed in sepsis, and the primary team, which can be either an intern, a resident, or the attending, or whoever, or can be an APP as well. They huddle around, confirm that this is sepsis, decide that this is sepsis from this organ being infected, or this is the source of infection, and activate the order set for sepsis. The reason for order set is not really because we're interested in order sets. It's because it has everything in the same place, and everything is ordered as stat. So you don't have a routine order that will wait for pharmacy to look at it an hour later, 2 hours later, or wait for the blood drawer to come back to the next blood draw. So that it's stat, so you can honor a 3-hour bundle that we are interested in. And based on the algorithm that's in there, if you pick on where you believe the sepsis source is, a series of antibiotics will come up as shining up for you to decide which ones you want to give. That is the first dose that you would give on the floor, and then later on you decide on what kind of antibiotic you want to do using another order set. But this is the primary thing. It also allows you to order a certain fluid. that you will give. This is based on all the teaching that you have received in the MICU and the tri-leaflet and the lectures that you've had and the mortality morbidity and the GPS that has been created for nursing in general in earlier phases, but later on was asked for all the add-on residents to take it. The checklist that was created by the ED, definitely, really, there's no difference between sepsis in the ED versus sepsis in the floor or whatever. Sepsis is sepsis. So what was developed was very applicable to any place, so we adopted it as well. And then we kind of went for the flow chart to outline what happens to the patient, and we created an audit tool, and we started this process in May. Some of you were involved in it, some of you know about it, but we really didn't advertise because we didn't really have all the components set, and it still is a work in progress. It's not yet an oiled machine, as they say. And there's a documentation tool so that we know how much fluids were given, what organ was dysfunctional, etc. And we just took it to the floor. Basically, all the science that Dr. Goldstein talked about, we tried to apply it at the bedside, like as simple as that, but applied it in a user-friendly, easy way. So for 3 months, we went and kind of, this is our work, and we looked at what's the good, what's the bad, what's the ugly. There's, I guess you guys know Clint Eastwood, I'm a fan of his. So the good was that everybody was interested. The teams were very responsive to the fact that there is this person from the ICU coming to help you out at the bedside. Nobody was offended by the fact that we're there, and everybody appreciated the help. And more importantly, when the patient is very critical, the nursing staff was very appreciative of the fact that somebody can hold their hand, make sure an IV is placed, make sure the antibiotics that are in Omnicells are ordered, and we can bring them to the bedside. And in case an ICU need is there, right away a phone call is made and the bed is made, and within like half an hour or so the patient is on the floor. When I was writing this slide, I thought I was really going to say the bad and the ugly, but then I realized I should be political. So where can we be better? It looks like we still enjoy ordering a la carte. Like a little bit of antibiotic here, a little bit of fluid here, ignoring the order set. When you activate the order set, a trigger code goes to the rapid response team. So in addition to radar, if an order set for sepsis is opened and signed, a person will come to the bedside to assist. If you do antibiotics here, fluids there, that trigger is not going to be there, unless the bedside nurse decides to call the rapid response team, and which puts it more human. And humans are going to forget. If you make it automated, it becomes much easier and much more standardized. And that's where the order set has been very, very, very helpful in getting our team up there at the bedside. Sorry. Thank you. So a la carte orders need to stop. So when you're thinking sepsis, or I just want to, like, when you're thinking sepsis, or somebody's not doing very well, let me adjust antibiotics, it means that you are concerned. Adjust them as stat, and use whatever is in the Omnicell, and then let's figure it out whether there is sepsis later on or not. When you review the progress notes, it's actually interesting. Everybody decide, okay, sepsis is there, and then 2 days later there's no sepsis, and you write upstairs that there's, oh, we discontinued the antibiotics, but you forget to correct down there that sepsis is still under ID. So our documentation is very confusing. Sorry. This is not COVID, though I'm in the COVID unit. Oh, thank you. You know, Matt, you should be around. Oh, thank you. So our progress notes, actually, if you sit down and read your progress notes, just do me a favor. This afternoon, go to one patient of yours and read 2 progress notes and sequentially. And you're going to find that our editing is relatively poor. The one thing that's not there is, in principle, When we go to the bedside to decide the fate of a patient, we have to come back to figure out what our response was. Like when you decide to give 500 cc's of a bolus, you cannot just give it and 5 hours later you come back and decide on the other 500. You have to come back and give or not give based on the certain response that you recorded. Simple tools, capillary refill, presence or absence of increase of crackles, improvement in heart rate, improvement in anything. Just say got better or didn't get better, or I stopped because there is this and that and whatever. Clearly, our fluid therapy, we are all confused about what to give. So is the literature. But the good thing is this frustration of how much fluids to give or not to give has triggered a quality improvement project in the MICU by a couple of our fellows to incorporate straight leg grazing all the time in the assessment. We just, our protocol is being built. It's not yet finalized, but when it is, it will be shared with everybody. And then you have to document something about Q-SOFA or organ failure or something. And it is important when you say, I believe this patient is septic, you have to say the source of infection is this, and the organ dysfunction that resulted from the sepsis is. So if you put this in any time, you will be very clear that this is what sepsis has affected. And what we're working on is now to kind of delete or execute, get rid of SIRS. We have to get rid of SIRS. You cannot rely on it. Radar is going to be the way to go. Several floors are incorporated in it at this point in time, but not all, and that will happen soon. The fluid therapy algorithm is being built and hopefully will be finalized in the next few weeks. Again, we didn't like the way we're documenting. It's very hard to follow, so we're creating a little bit of a different documentation, and the tools are us, and we're simplifying a few things. Now, the one good thing is we have to kind of do a group education that will self-perpetuate. So I volunteered few resident champions. And whoever wants to join us, they're more than welcome to call and say, I want to be part of the team. We haven't met yet as a group of resident champions. The role of the resident champions is going to be the ongoing educators on every part of the hospital, on the floors, in the MICU, or in the ED, whatever. And they, with the help of some of our fellows and our new faculty, Leila Sangari, you all know her. She was one of our fellows from last year. She enjoys this stuff a lot. We're going to create different simulation scenarios from actual cases that we think could have been managed better. And from there, keep on doing it every single time. Then we get feedback, and then we go back to the drawing board and then readjust our program accordingly. That's all I want to say. The science was by Dr. Goldstein. I'm just a bedside person.
Hey, Dr. Goldstein and Dr. Hajjal, we got time for one or two comments or one or two questions that you want to follow up with something, Jessica?
Absolutely.
Yeah. I don't see any questions.
Can I say something?
No, Dr. Fries, of course.
So this was great. Thank you both, Jessica and Rana. So going back to the SIRS, not only it's not specific, it's also not sensitive. It's very important to remember that you can miss, there are studies that showed like you can miss 1 to 8 patients who could have sepsis, meaning infection with organ dysfunction, by just looking at SIRS. And to reiterate that severe sepsis does not exist clinically, but like Jessica said, it might still exist for coding purposes because there is always a lag between clinical medicine and coding. Coding is always behind by like a lot of time. The last thing that I wanted to say, it doesn't really, I think there is a new study going back to fluid resuscitation to build on the SMART. There is a new study that just was published called the BASICS that compared normal saline versus plasma light. And normal saline was as good. So I don't think as resident on the floor, you should really fret what if you don't find LR give the normal saline. As long as you give it quickly, it's okay. The problem becomes if you give too much. And the last thing, I want to advertise the Pneumonia Order Set. So Order Set, there is also a great Pneumonia Order Set. That's, please use it. We've been advertising for it. We're going to send a system-wide email soon. It's very good for those people in the sepsis. It will come to you under the sepsis order set, but without sepsis. Please use it. Dr. Hajjal put a lot of effort in doing it. It's algorithmic. It's helpful as a teaching tool and as a great tool for patient care. Thank you.
Thanks, John. And I see Ken Remy had your hand up. Last comment, unless our speakers want to say one last thing, because we're a couple minutes over time and some people have clinics and so on.
This is great. I appreciate it. No, this is great. So as a sepsis investigator, I find this quite interesting, obviously, and I think this is great to have this sepsis RS group. We do know that, fluid overload is actually seemingly a bigger problem, and ANZIX and Process and Promise certainly have depleted and waned enthusiasm from the earlier 10-year single center study of only 250 patients. So it seems when you take out in the bundle early antibiotic administration, most of the bundle falls away, and it's not actually as efficacious in 2021 with early diagnosis. So with this sepsis RS, is time to antibiotics going to be one of the metrics that's at least obtained, and as we go forward, feedback given for time to antibiotics?
Yes, Ken, you're absolutely right. The time to antibiotic is the most important, and in reality, with the help of pharmacy, we have put all the antibiotics that are ordered stat in every Omnicells on the floors. So the minute the order is there, the nurse can go to the Omnicell and pick it up. So the time to antibiotics actually is pretty good. We've had a couple of mishaps because the one was expired in one floor, but this is something we're looking on more frequently. Go ahead, Jessica.
Yeah, our HRM is tracking those numbers, and our times are they're excellent. I think we're around 65 minutes. That's the goal for all the community hospitals, and CMC is doing very well as well. And granted, most of those are in the ED. We order everything stat. The Omnicell's right down the hall. So we need to work on that for the floors, and I think that that's an excellent metric to be looking at the success of the Sepsis RS bundle.
Oh, absolutely. As for fluids, actually, we're gonna, there's even, I'll take it one more step about fluids. We always say, well, give 500 and figure it out, but there's new data to say don't do that. Figure out if they need it and then give it. So hopefully we'll figure it out soon and put it in an algorithm.
There's an old joke about infectious disease doctors. If you ask 2 infectious disease doctors an antibiotic question, you get 3 answers. If you ask 2 critical care doctors a fluid question, you get 3 answers. Anyway, just kidding. I want to thank Rana and Jessica for a fantastic kickoff for Grand Rounds this year, and for all the work that you guys have done on this really critical, HRM quality care initiative. So thanks, guys.
All right, thanks.